Good evening, everybody, and welcome to the last in the series of 4 webinars covering the BSP development of the S3 treatment guidelines. It's always a little bit sad when these things come to an end. I remember the classification guidelines coming to an end. We've had 4 very good sessions, or we will have done by the time we finish this one, 4 very good sessions together. I hope you've enjoyed them and I hope you've got a lot out of them. The webinar series has been brought to you free of charge, thanks to a number of our partner sponsors, and tonight's webinar is no different. We are supported tonight by our friends at Oral-B, and for that we are very grateful. I'm sure the launch of their new electric toothbrush, the IO, didn't pass you by last year, and if it did, where were you? And I'd encourage you to contact your local reps and get more information on that. They're excellent new product. Before I introduce our speaker tonight, as always, I'm going to run through a bit of housekeeping for anybody who's not been to one of our webinars before. The way the evening is going to run is that I'm going to introduce our speaker. They're going to present for about 45 to 50 minutes, and you can ask questions at any point through the webinar by typing questions into the question panel on the right-hand side of your screen. Due to the large numbers of attendees tonight, I will be collating the questions and asking as many of them as possible, but it may not be possible to get through all of the questions this evening. We will also be keeping the questions specifically to Nicola's presentation. Following the webinar, you'll be sent a link to record your feedback, and then you'll be able to download your CPD certificate. This will only be sent to you in the next few days. It's nothing you need to worry about this evening. It might even be early next week. So keep an eye out for that in your inbox. Yet again, our speaker needs no formal introduction. I'm not going to read their CV. Over the last few webinars at this point, I've cracked a few jokes about missing the football and the Liverpool games with Nikos Donos, or Ian Chappell being locked in his office by Big Dave, the hospital porter. But tonight, I just wanted to be a little bit serious for a minute. Our speaker tonight, Professor Nicola West, has lived and breathed this document for over, well, at least 18 months. Being part of the original EFP workshop before bringing the document to the BSP and spearheading their development process. The development process alone has been a year of her life. This time last year, we were just starting the development process, and whilst everybody else was Googling the word furlough, I was Googling the word development because I didn't know what it meant. Seeing what goes on behind the scenes, I cannot stress to you how hard Nicola works for the BSP and for the good of perio in the UK. And the current BSP development is purely down to her drive and effort. And I'm sure she's going to tell you how it's been a team effort. And yes, it has. But I've got to say a huge personal thank you on behalf of myself and the Society for all the work that Nicola has done on this. And we can't forget Moritz, who's also been a huge part of the team. So thank you, Nicola, for everything you've done. Let's face it, it's not like you haven't already got a busy day job. Enough of me prattling on. On that note, I'm going to hand over to Professor Nicola West for her presentation of step 4 of the S3 treatment guidelines. Welcome, Nicola.
Oh, thank you, Ian. That was a lovely introduction. You're always brilliant to have as a moderator. Thank you. I have to say these guidelines have been quite a journey for the BSP, but a highly successful one. And it is a team effort. You know, everybody's played their role. And as I have the opportunity, I would like to thank people, in particular BSP Council, Paula. Paula has worked as hard as I have and just achieved so much. Tam, the workshop participants, the chairs, Moritz, Inna, and of course you, the BSP membership, for your continual support. So just a really big thank you to everybody. So let's start the presentation. Good evening, BSP friends, and welcome to the 4th webinar in this series on the BSP UK practice guidelines for the treatment of periodontitis. Step 4, supported periodontal care, ongoing lifelong care for our patients. As you've heard this evening, this webinar is sponsored by Oral-B, and I would personally like to thank Eva for your support, and I'd also like to declare that I've been paid an honorarium for giving this webinar. To set the scene, which I think is important as to why we need these guidelines, These new guidelines aim to improve the overall quality of periodontal treatment, reduce tooth loss associated with periodontitis, and ultimately improve overall systemic health and quality of life. Periodontitis is the most common chronic inflammatory, non-communicable disease of humans. And Casebound's Global Burden of Disease paper from 1990 to 2010 shows severe periodontitis affects 11% of our world population and is the 6th most prevalent chronic condition. The prevalence of milder forms of periodontitis may be as high as 50%, and in the over 65s, 60%. And most importantly, periodontal diseases are, in the majority, preventable. These are really important facts with which you can engage your patient. Periodontitis is a major public health problem due to its high prevalence. It leads to tooth loss, disability, and it negatively affects chewing function and aesthetics. And of course, leads to social inequality and significantly impairs quality of life, and accounts for a substantial proportion of the edentalism that we have in the UK, with significant dental care costs. And as I said, in the majority, preventable. If left untreated or inadequately treated, periodontitis leads to loss of tooth-supporting tissues and teeth. Severe periodontitis and dental caries are responsible for more years lost to disability than any other human disease. And of course, it's associated with many systemic diseases, but in particular diabetes, cardiovascular disease, and dementia and adverse pregnancy outcomes. On a global scale, periodontitis is estimated to cost $54 billion in direct treatment costs and a further $25 billion in indirect costs. And periodontitis contributes significantly to the cost of dental diseases due to the need to replace teeth. Now, I don't think gum disease is highlighted enough to the UK public or other medical healthcare professionals by our public health system. And in fact, many general medical practitioners know very little about oral health. And one of the BSP strategic aims is to educate the public and patients. And this is driven by the EFP oral health prevention strategy that the BSP highlights. That's Gum Health Day on the 12th of May, using powerful images like this, a blood-stained apple. And of course, the day coincides with National Smile Month, led by the Oral Health Foundation, which increases the impact. Now, there's a lovely quote, which I'm sure you've heard. Now, this is from Roy Page's publication. In patients with moderate to severe periodontitis, the total area of pocket epithelium in direct contact with the subgingival biofilm is about the size of the human palm, and in advanced cases, much larger. And you'd certainly be going to the doctor, wouldn't you, if your hand looked like this and was infected. I work with Professor Raimondo Ascione, who's the chair of cardiac surgery and translational research in Bristol, and he leads cardiac surgery for the Southwest. And we've been working on the associations between hospital-acquired infections following cardiac surgery and oral health. We believe that severe periodontal disease can influence wound healing. And to put this in perspective, Raimondo has aorta slough out or infected valves when he has a problem. So a little bit more than us. Now, Raimondo is passionate about oral health, a rare medic, and in COVID, he saw the oral health of many of his patients deteriorate to the extent that he was concerned about operating on them, and for the first time said that their oral health had to improve before he did treatment. Which brings me very nicely onto our paper, the BSP implementation of the European S3 level evidence-based treatment guidelines. Now, S3 means the highest level of evidence, and that's evaluated from formal evidence, grading and synthesis, combined with clinical expertise of a broad range of stakeholders. We asked a number of people to come along to our workshops. We assessed 15 systematic reviews and produced 62 clinical recommendations. and then wrote a stepwise process mapped to the 2017 new perio classification. The aim, of course, of step 4 is to prevent periodontitis recurrence and progression after successful completion of active treatment. And it must be performed in all patients regarding their condition of being at high or low risk for periodontitis recurrence or progression. It consists of a combination of regular, preventive and therapeutic interventions. So how did the BSP come to write our guidelines? Well, it was derived from the EFP guideline, and that was developed by an international working group of periodontists and expert stakeholders. The guideline document was finalised and formally voted on in the 16th European Workshop in Perio in Logroño in Spain in 2019, a long time ago when we were face to face. And this guideline and the supporting systematic reviews, which were 15, were then published in the JCP, and you can see the paper here. Now, the guideline was developed under the auspices of the EFP, and we employed an independent moderator, Professor Nicola, who's an amazing lady, kept us all in order, in check, and not easy with a group of academics like this. And she oversaw the process with the EFP Working Committee. And I'm sure you recognise the British input here with Ian Chappell and Moritz Kevschel. Now, this was the first time the EFP had undertaken a workshop using this methodology, and this is the first time for dentistry. So this is a really big step for us. Now, each country could decide how they would like to take the EFP guidelines forward. A national society could translate it, maybe with a commentary, adopt it, or adapt it and do grade development, which is, of course, what we did in the UK. And I'd like to thank Moritz for this graphic. And this is how the EFP national societies informed us they were going to implement the guidelines in their country or not. And you can see here that Spain, Germany and the UK undertook the full development process. Yes, that's right, it's not a typo. And the papers were all released actually about the same time, which was early February 2021. Paula Dunn and I then set about the task of developing these guidelines for the UK healthcare system, both NHS and private, which was a tall order but extremely rewarding. And at this juncture, I would really like to thank Paula for all the hours that you put in, Paula. Your fantastic work enabled us to achieve our goal of these guidelines. So a big BSP thank you. Here are the ambitious timelines that were, I have to say, facilitated by COVID. I don't think we'd have got it done as quickly if we hadn't all been at home, as all the participants were free. With the lovely Ina, who agreed to be our independent moderator as well for our guidelines, we then published our UK paper in another high impact journal, which I think is a great achievement for the BSP. The British implementation followed the same process as the EFP one, with the underlying evidence updated, because of course we were now 6 months later in the year when there could have been new information, and if there was, this was included if it felt appropriate. And we invited 75 delegates from 17 stakeholder organisations, as you can see here on the screen, and we were divided into 3 working groups. We all declared conflict of interest, which is really important, and the BSP funded this initiative. The main difference from the EFP was we had patient forum members in each group, and they were instrumental in their thoughts and comments in the development of our guidelines. And of course, it was Ian Needleman's fantastic initiative to form a patient forum, and we now have a patient forum member on council, which is fantastic. The PICO questions were the same, and of course developing a research question is one of the challenging tasks a researcher encounters when initiating a project, and these are of course vitally important. Here is the strength of recommendations table, the grading table. You can see here we can have an A, which is a strong recommendation, stronger with the 2 arrows up than down. B, a recommendation. Again, we have an arrow up or we can have it down, suggest not to recommend. And O is an open recommendation, which may be considered. If we look below that table, you can see the strength of consensus determination scheme. I have to say it's a very robust and ordered process. At the time, I remember we were in Segovia and voting on the 62 guidelines, which did take quite a while. And I have to say that the EFP workshop voting procedure was worse than the 2019 Brexit voting when Boris was elected. So that tells you how much time we spent on it. 3 working groups were formed, led by myself and Moritz Kebschel, with 2 chairs for each working group. See how many faces you recognise. The working groups worked on their own and then came together for consensus. And group 1, this lucky group, assessed both step 1 and supportive periodontal care. So a lot of recommendations for them to vote on. Here's group 2 and group 3. And we thank all the participants for the time that they gave the BSP in developing these guidelines. The order of events were as follows, very labour intensive. Let's look at the steps of periodontal therapy. Of course, we need to identify a susceptible patient having periodontitis and to confirm the diagnosis and stage and grade. Once we've done that, then we treat according to this stepwise approach. And it is an essential prerequisite to therapy to inform the patient of the diagnosis, including the causes of the condition, the risk factors, the treatment alternatives, and the expected risks and benefits, including the option of no treatment. This brings me to this lovely graphic. Thank you, Ian Chappell and Moritz Kebschel, for lending it to me. As I said, first of all, we need to educate our patient and come up with our diagnosis and care plan. We then have our first step of therapy aimed at changing behaviour, motivating our patient, that you would have heard in our first webinar from Moritz. Then we have our intervention with our subgingival biofilm and calculus removal plus adjunctive agents if required, flowing on to reassessment and treatment of the areas that have not responded well. This may include surgery or resection or regeneration. And then we move into supportive periodontal care. It's more than an exit, I would say. It is lifelong, ongoing care for our perio patients that once a perio patient, remain a perio patient. And Ian and Moritz have constructed this beautiful graphic, and thank you again to you both, looking at initial periodontal therapy, looking at the basis of the therapy, step 1, going on to re-evaluating and step 2 with our subgingival instrumentation, and on then to re-evaluation of step 2 and management of residual pockets, and on to my area for tonight, that's step 4, the supportive periodontal therapy. And I'll now go through the 20 guidelines in supportive periodontal care. So supportive periodontal care, the first point, recommendation 4.1, at what intervals should supportive periodontal care visits be scheduled? And you can see here that both from the EFP and from the BSP implementation that it suggested that they should be between 3 and 12 months. And these supportive periodontal care visits should be tailored by the patient's risk profile. If you look at more detail of the studies, and particularly the Trombelli study, which was also our study, it suggests that supportive periodontal therapy should be every 3 to 4 months. Again, that's supported by Pollack's paper following surgery, and by the 2014 European workshop, again another paper by Trombelli and also Mariana Sands. And Christoph Ramsier in his paper here also suggests that we can look at patients' bleeding scores and plaque scores and put these into an algorithm to get finer detail as to when we should see them for that review appointment. So we strongly recommend this recommendation, and this was unanimously voted upon. If we look now at the second point in supportive periodontal care, 4.2, is adherence to supportive periodontal care important? And you'll see here that both the EFP and the BSP strongly recommend that adherence to supportive periodontal care is strongly promoted, as it is crucial for long-term periodontal stability and potential further improvements in periodontal status. And we know that there are greater rates of tooth loss and disease progression in patients with irregular compliance versus patients with regular compliance. Also, we have conclusions from the 2014 European workshop, again based on Trombelli's work, that concluded that compliance with the preventive professional intervention is critical, PMPR, and this is based on retrospective observational studies. At this point, I am going to highlight that we have introduced some new terminology, which if you've been listening to all the webinars, you will have picked up by now. Supragingival PMPR and a subgingival PMPR, that's professional mechanical plaque control or removal. And we have constructed a glossary on the BSP website on the S3 page, so that you can see all the different terms and how they all link together and the preferred terms we like to use at the moment. Recommendation 4.3 is oral hygiene instruction important and how should it be performed? The BSP and the EFP concur, and we have the same recommendation. It was adopted. The grade of recommendation was grade A, and this was strong with 2 arrows. And we recommend that repeated, individually tailored instructions in mechanical oral hygiene, including interdental cleaning, is necessary in order to control inflammation and disease progression. Now, this work stems from Dagmar Slott's work in 2020, and there's a strong consensus that mechanical plaque control is the bedrock to successful perio management and supportive perio care. All surfaces exposed to the formation of intraoral biofilm have to be cleaned mechanically. Some of them will not be reached by toothbrushes, even under optimal conditions, and this is when we then use interdental cleaning aids. And it's essential to use these aids in order to maintain interproximal gingival health, and in particular for secondary prevention of disease. Now, there are different aids we can use. There are interdental brushes and rubber elastomeric sticks, oral irrigators, floss. They all have potential side effects if they're not used correctly, and it's important for the oral healthcare professional to help our patient to use them to the best of their ability and to maintain health. If we turn to recommendation 4.4, how should we choose an appropriate design of manual, power brush and interdental cleaning devices? If we look now at the EFP and BSP comments on this recommendation, you can see that we need to take into account patients' abilities and needs and preferences when choosing a toothbrush design and when choosing an interdental brush. The strength of the recommendation is very high, as you can see here, and we had good consensus. Now, there's actually a lack of evidence about which products we need to use, and dental care professionals in practice are best placed to choose for that individual patient and their needs. Clinical evidence indicates that the efficacy of interdental brushes depends on the size of the brush and the space, and those interdental spaces can be very variable. So we leave it up to the clinician to determine which brush to use in which area and which devices to use. Recommendation 4.5, should we recommend a powered or a manual toothbrush? the EFP and the BSP here had an open recommendation, as you can see here, the O with a may be considered, and the power brush may be considered as an alternative to the manual brush. Now, this is again work by Dagmar Slot, and the evidence was based on the systematic review underlying this guideline. Toothbrushes vary in size, design, length, hardness of bristles, arrangement of the bristles, and some manufacturers have claimed superiority in modifications such as bristle placement and length and the stiffness of the bristles. And power toothbrushes have various mechanical movements, the oscillating and rotating, different features on these brushes. But the evidence at the moment is an open recommendation. We need some more data, although of course, as we all know, there are a number of individual studies that show that the power brush is better at plaque reduction and gingivitis reduction. Recommendation 4.6, how should interdental cleaning be performed? The EFP wrote, if anatomically possible, we recommend that toothbrushing should be supplemented by the use of interdental brushes. The BSP adapted that to say we recommend that toothbrushing should be supplemented by the use of interdental brushes where anatomically possible for patients in supportive perio care. The grade was a strong recommendation, and it was a strong consensus. Now, this is Dagmar's systematic review, Dagmar Slot, who found evidence for significantly better cleaning with interdental brushes as adjuncts to toothbrushing alone, and a significantly better cleaning effect of interdental brushes than floss. There was some evidence for trauma due to interdental brushes when not used properly, but it's important for the oral healthcare professional to make sure that we personalise this care, we give individually tailored instruction to our patients so that they can clean well. So that's really critical, that it's professional care that's given, and that significantly outweighs any other risks. Recommendation 4.7, what is the value of dental flossing for interdental cleaning in periodontal supportive care? Both the EFP and the BSP implementation agreed, and we adopted the guidance. It was a grade B recommendation, and with the arrow going downwards, so not that strong. And the recommendation was we do not suggest the use of floss as the first choice method of interdental cleaning for patients in supportive perio care. And remember, these are perio patients. They've been diagnosed as perio patients and are being looked after long term as such. They're not healthy periodontium patients. Now, this is one of Dagmar's systematic reviews again, and they found significantly better cleaning of interdental brushes than flossing, and there was a moderate risk of trauma due to the interdental brush or floss when it wasn't used properly, which makes me reiterate that it is crucial for the oral care professional to give individualised, personalised, tailored care for our patients and to adapt to the situations we find in order to help our perio patients stay in supportive perio care. Recommendation 4.8. What is the value of other interdental devices for interdental cleaning in supportive periodontal care? And you can see here the grade of recommendation is B, so it's recommended with an upward arrow, and the British have adapted that guideline to suggest that the use of other interdental cleaning devices in interdental areas not reachable by interdental brushes are suitable for patients in supportive periodontal care. And I think if we look at the data, we look at Dagmar's data, other interdental cleaning devices have been included, like rubber and elastomeric cleaning sticks and wood sticks and oral irrigators. And although there are very small and fine interdental brushes available on the market, not all interdental spaces are readily accessible to all those brushes. So there is not a lot of evidence. There is, in the systematic review, some work assessing the adjunctive oral irrigator, and that has demonstrated a significant effect on gingival inflammation, but not plaque scores. So again, we need more information in this area, more research. Recommendation 4.9, what additional strategies and motivation are useful? The consensus here from the EFP and the British implementation is that we are following the recommendation in the first step of therapy, and you can see that there are many overlapping themes between the first step and supportive perio care. The recommendation is we recommend emphasising the importance of oral hygiene and engaging the periodontitis patient in behaviour change for oral hygiene improvement, and this is 1.2 in the first step. The strength of consensus was strong and the grade was B with an upward arrow. Now, we know oral hygiene instruction and patient motivation in oral hygiene practices should be an integral part of patient management during all stages of periodontal treatment, and different behaviour interventions as well as communication and education methods have been proposed to improve and maintain the patient's plaque control over time. We know that we have good evidence for smoking cessation, for controlling diabetes. We don't have such good evidence on physical exercise and dietary counselling. So that recommendation has been adopted by the BSP. Recommendation 4.10, what is the value of adjunctive antiseptics or chemotherapeutic agents for the management of gingival inflammation? The UK BSP implementation adopted the EFP guidance that the basis of the management of gingival inflammation is, of course, self-performed mechanical removal of the biofilm, that's toothbrushing. However, adjunctive measures like antiseptics may be considered in specific cases as part of that personalised treatment approach. And we know that to control gingival inflammation during periodontal maintenance, the adjunctive use of agents can be very beneficial. And these can be delivered as toothpastes or mouth rinses or both. And we also know, which is important, that both toothpastes and mouth rinses are widely accepted by the population, so they're excellent delivery vehicles. Now, the grade of this recommendation was 0, so it's not strong, and there was good consensus on that. Recommendation 4.11, should adjunctive chemotherapeutics be recommended for patients in supportive perio care? And if we look at the BSP implementation, we have adopted the EFP recommendation in that the use of adjunctive antiseptics may be considered in specific cases to help control gingival inflammation for patients in supportive perio care. And also, B, we do not know if other adjunctive agents, this is like probiotics, prebiotics, anti-inflammatory agents, or antioxidant micronutrients, are effective in controlling gingival inflammation in patients in supportive perio care. Now, this is Elena Figueiredo's work from the Madrid group, and the grade of recommendation is open. You see it's an O there, we had good consensus on this. So if we talk a little bit about the background to this recommendation, in order to control gingival inflammation in SPC, the adjunctive use of some agents is proposed, and these are mainly the antiseptics. But sometimes, you know, we see other agents use the probiotics, the prebiotics, anti-inflammatory agents, and the micronutrients. However, the majority is delivered as toothpastes or mouth rinses. And the adjunctive use of antiseptic agents is really proposed for those subjects who are not able to effectively remove the supragingival biofilm by the use of mechanical toothbrushing, every day, twice daily toothbrushing. And actually, this is the same recommendation as in the 11th European Perio Workshop back in 2014. Now, most of the studies that assess the adjunctive benefits have been performed in general populations, and usually with regards to plaque and gingivitis. And therefore, you need to consider different factors when recommending an adjunctive agent. You know, you need to look at how that patient is cleaning, what their needs are. They should be using a toothbrush with fluoride toothpaste. But if they are not controlling their biofilm effectively with mechanical plaque procedures, then you can decide to utilise mouth rinses and toothpaste with a specific effective agent, and that would be following, again, the personalised approach to patient care. And you'd consider the local factors like anatomical factors or accessibility, and also general factors, systemic health, general health, frailty and manual dexterity. The most frequent delivery method, however, for these antiseptic agents is, of course, toothpastes and mouth rinses. Recommendation 4.12, which antiseptic is the most effective in dentifrices? And here you can see that there's some variation between the EFP recommendation and the BSP implementation. The BSP wrote the following statement: a specific recommendation was unable to be made and further research is appropriate. The EFP statement recommendation is products containing chlorhexidine, triclosan copolymer, and stannous fluoride sodium hexamethophosphate for the control of gingival inflammation should be prescribed if needed. So let's talk a little bit about the background to these decisions. You can see here the grade of recommendation was B, and for the British, the consensus was a simple majority. Now, we know in order to control gingival inflammation in SPC, we can use adjunctive agents, and these products can be delivered as dentifrices, which is really the ideal because they're used every day and people are very familiar with them. So it's a good delivery mechanism. The work was done mainly in Madrid. You can see here much of it's Elena Figueroa. And in that systematic review, the main one, the adjunctive use of 14 different toothpaste formulations were evaluated for controlling gingival inflammation with clear heterogeneity in the number of available studies for each product. This is the 2020 work. And this is really important. In previous published work, chlorhexidine, triclosan copolymer were the most effective agents for plaque reduction, but no clear differences were observed for gingival index control. Additional factors for the British were discussed in that chlorhexidine in these studies was a gel rather than a toothpaste. Triclosan products are not available in the UK due to concerns over effects of hormone levels, absorption of this product, and potential long-term public health risks, which left us with our stannous fluoride data to consider, which has good efficacy, but we cannot say it's the most effective at this time, and more research is needed. So hence the difference between the EFP here and the BSP. Recommendation 4.13, which antiseptic is the most effective in mouth rinses? And you can see here that the EFP and the BSP concurred, and the recommendation is that if an antiseptic mouth rinse formulation is to be considered for the adjunctive control of gingival inflammations in patients in SPC, we suggest the use of products that contain chlorhexidine, essential oils, or cetylpyridinium chloride. The recommendation level was grade B with an upward arrow, and we had good consensus. And if we look at the background, of course, we know that mechanical plaque control is the best, but we can supplement this with adjunctive agents, and certainly mouth rinses are shown to be good delivery vehicles. In Elena's systematic review in 2020, the adjunctive use of 11 mouth rinse formulations were evaluated for controlling gingival inflammation, and that's important, with clear heterogeneity in the number of available studies for each product, which is, of course, a problem for us. The results show that all three of those can have efficacy, and in previous studies, chlorhexidine and essential oils were ranked as the most effective agents for plaque and gingivitis reduction. So we have a couple of recommendations there for you for good effective mouth rinses for plaque and gingivitis reduction. Recommendation 4.14, what is the value of professional mechanical plaque removal, PMPR, as part of SPC? And you can see here that the BSP and the EFP concur, and the paper, that's our paper, that's myself and Nick Clayton and Alex Pollard wrote this with Leonardo Trombelli,
And we agree the statement performing routine professional mechanical plaque removal, PMPR, to limit the rate of tooth loss and provide periodontal stability improvement is part of the supportive perio care program, which I all think we agree. It should be administered on a routine basis and be an integral part of the supportive care plan, and it has been shown to reduce tooth loss and limit attachment levels in both long and short-term studies in patients. So we do recommend this. What I would say at this juncture, that this is not a scale and polish. I think we have reiterated this throughout all the webinars, and it's written clearly in the glossary what is PMPR on the BSP website. PMPR is a defined set of processes for a perio patient. It is not a scale and polish. Recommendation 4.15, should alternative methods be used for professional mechanical plaque removal, PMPR? We're getting used to that term now, aren't we? In supportive perio care. Well, both the EFP and the BSP agreed, and the BSP adopted the recommendation that we do not suggest replacing professional mechanical plaque control with alternative methods such as the YAG laser in patients in supportive periodontal care. The grade of recommendation was B, a downward arrow, and the consensus was strong. Now, if we review the literature, this is what it supports, and there isn't enough evidence to suggest that this laser is an alternative method to conventional PMPR, no statistical differences. Also, we have to think of the cost benefit and cost effectiveness analysis, and that's missing in this case, but it's certainly going to be relevant when considering this particular option. If we now turn to recommendation 4.16, should adjunctive methods be used for professional mechanical plaque removal, PMPR, in supportive perio care? And the BSP agreed with the EFP with the recommendation we do not suggest the use of adjunctive methods, and that's like sub-antimicrobial doses of doxycycline or photodynamic theory, to PMPR for patients in this phase. And I think you'll all agree with that. The grade of recommendation was B, but with a downwards arrow, and we had good consensus. If we look at the background, we can look at that systematic review by Trombelli, which is our review as well, the Bristol review. It was with patients at least a year's follow-up, and it's interesting actually how many studies don't look at that length of time, which of course is important, and there was no evidence that using these adjunctive aids helped in the stabilization of perio patients. So you have a clear recommendation there. Recommendation 4.17, what is the value of risk factor control in supportive periodontal care? We recommended risk factor control interventions for patients in supportive periodontal care, which was the same as the EFP, so we adopted their recommendation, and the evidence is strong, grade A, with 2 upward arrows and good consensus. And the periodontal patients, of course, benefit from additional risk factor control interventions to improve the maintenance of their periodontal stability, and those interventions would include education, which should be staged and adapted according to the individual needs of that patient. Recommendation 4.18, what is the role of tobacco smoking cessation interventions in supportive perio care? This is based around Ramsier's work, and we adopted the same recommendation of the EFP in that we recommended the implementation of tobacco smoking cessation interventions for patients in supportive perio care. This was a grade A, strong recommendation with 2 upward arrows and good consensus, and we've really covered this in other parts of the recommendations, so I won't go into it again. I'll just refer you to Ramsier's work, which is excellent. Recommendation 4.19, what is the role of promotion of diabetes control interventions in supportive perio care? Again, this is for Christoph Ramsey's work from the Bern group, and the BSP recommended adoption, suggesting promotion of diabetes control interventions for patients in supportive care. The grade of recommendation here was B, with an upward arrow and good consensus. And we know that perio patients may benefit from promotion of diabetes control interventions to improve the maintenance of their perio stability. And the intervention may consist of patient education, including dietary advice and counselling, and possibly referral to specialist glycemic control advice. And again, we go into that more in the earlier parts of the recommendations. And recommendation 4.20, what is the role of physical exercise, dietary counselling or lifestyle modifications aiming at weight loss in supportive periodontal care? The EFP and the BSP concur, and the BSP adopted the EFP's recommendation that we do not know if physical exercise or dietary counselling or lifestyle modifications aimed at weight loss are relevant in supportive perio care. The recommendation is an open recommendation, so may be considered, and we wait to gather some more research in this area. Overall evidence from the medical literature suggests that promotion of physical exercise interventions may improve both treatment and long-term management of non-communicable diseases. So, that's perio disease. In perio patients, the promotion may consist of patient education specifically targeted at the patient's age and general health. So we await more research in this area. That concludes the recommendations for supportive periodontal care. And as you can see, if you go on our website, we have dedicated a page to the S3 treatment guidelines with the infographics, and you can follow the QR code to get a little video of us talking about the guidelines. We have interviews with key opinion leaders and stakeholders that I urge you to watch because they're excellent, and a glossary of terms because we have introduced some new ones. We will also be writing a BDJ paper with the lay guidelines for patients and the public, and that hopefully will be coming shortly. I have a little fun video for you here. This is the speeded up version of filming for the video on the QR code. It was an amazing day, but absolutely raining, but we all had a really great time. A group of us have been working on the infographic flowchart, as you can see here, and it's aimed to give you an overview of the paper in a simple way, and we hope you'll enjoy using it. It is coated in N9 pure silver, which is designed to provide antimicrobial performance and is safe and natural. We are very grateful to GlaxoSmithKline for printing 80,000 flowcharts and starting that distribution process, sending 5 copies to 8,000 UK dental practices. So that's over 40,000 copies. And in addition, we're sending 6,000 copies to all the dental schools. We'd also like to thank the British Association of Dental Therapists and the Royal Air Force for helping with that distribution. As I said, I hope you find this a really good educational resource. What's next? Well, we have another workshop. We have the 17th European Workshop on Periodontology, Evidence-Based Guideline for Periodontal Therapy Stage 4 Periodontitis, which is another S3 level guideline. Hopefully 4th to 6th of July, we will all go to this beautiful location just above Madrid in Segovia and be able to hold that workshop. We will let you know, and we will then bring it back and develop it in the UK. So be ready next year for another guideline. I hope you've enjoyed the webinar this evening and the other 3 in the series. The paper is an interesting read, but it is a little heavy going, I'll admit, and I hope these webinars have made it far more interesting and enjoyable for you. You will have the infographic flowchart soon too, which I hope you'll all really enjoy. So we can all start using the new evidence-based perio guidelines. And I'm very happy to take any questions.
Thanks, Nicola. That was great. I don't know how you managed to fit all that in, considering you also gave the history of the development at the start as well. So yeah, well done for keeping to time. There are a number of questions that have come in. I'll try and take them in a sort of semi-logical order. The first question: what role can we play as dentists, hygienists, and therapists in the detection or management of suspected diabetic patients?
Thank you, Ian. That's a good question. From my perspective, when we can't get resolution, you've got good oral hygiene, the patient's well, you feel the treatment's gone well, then I think it's probably time to refer. We can, in non-COVID times, I'm not sure at the moment, but you can go and get a fasting blood glucose test done at the pharmacy. So my view is, if you feel that something's not right, and you do get a feeling for this, and you've done it for long enough, you get a feeling for something's not right, then it's time to investigate. Obviously, if you're in a more hospital-based environment, we can take bloods and do other tests. So I would use your instinct, and I would ask them either the patient to go to the doctor or to go to the pharmacy and take that forwards.
Yeah, that sounds perfectly sensible. And I think just obviously looking out for other risk factors other than non-responding perio. So all the classics, the overweight, over 40s, sedentary lifestyle patients, family history of diabetes. If they've got multiple other risk factors, then perio is just part of the equation, isn't it?
Totally agree. It's that perfect storm, isn't it? And I love the way the Americans actually look after the diabetic patients, which Phil Preshaw talks very eloquently on, in that the patient's the centre, and then we have all these risk factors around, and you do a chart looking at their all the different systems and giving crosses and ticks as to what's going on, which is a different way of looking at it. The patient really at the centre. So yes, totally agree with you. Looking at all those other all those other indicators that might be relevant.
Yeah. You may have answered this indirectly in your discussion, but the question's coming in: does polishing, i.e. prophy, have a role to play in modern supportive periotherapy? Just polishing.
Okay, so yeah, so this is one of the areas that the BSP would like to clarify, in that we want to really differentiate between a scale and polish and PMPR. So for the perio patient, it's important that we get rid of stain, but a PMPR is so much more than doing that. It's looking at everything that we've documented down in that glossary, and it is different from the routine scale and polish. So yes, we want to remove stain and overhangs and anything else that can attract plaque, but it's a lot more than the scale and polish.
Okay, great. Next question is quite a long one, but that sort of makes sense to me. Supportive periodontal care will no doubt be influenced by the very strict guidelines that were set out for periodontal stability in the 2017 classification. What percentage of patients realistically do you think can achieve perio stability, whether that be in hospital or in practice?
Well, that's a really interesting question, actually. And funny enough, we've just been looking at that, and we've been doing it because we are. This is the EFP now. We've got an article in The Economist coming out looking at cost benefit, which is really interesting, and we've been looking at these particular percentages. So let me just bring up the figures that I had there for supportive care. If you'll give me a moment, I'll come up with them. Let me just have a look.
I feel like we're getting something hot off the press here, Nicola. Yeah. This feels like an exclusive.
It is. Let me just have a look, because I think what's really interesting, actually, Ian. This is probably shouldn't say this, but I will, because this is the BSP. We've asked people in all different countries, and we've all come up with roughly the same figures, which is really interesting. I'm just getting them up. Sorry, I'm trying to multitask here.
That's okay.
I've got a table with them. So yeah, this is what I want. So sorry, ask me the question again. And I tell you what we've actually done. We've actually looked at how many people we think are in step 1 and how many go from 1 to 2 and 1 to 4 and 2 to 3 and all this sort of thing. So ask me the question again and I'll tell you my percentages.
The general gist of the question was related to, given the strict guidelines for the definition of what we now call stability. So, you know,
yes.
From this classification,
4. Yep.
How many patients what percentage of patients do we expect or do we think we can get to true stability?
Well, if I give you some individual ones, so there are obviously some people that will go 1 to 4. So I reckon that's about 10%. And please, you know, you have a guess too, because it is my guess. So there are some there. 2 to 3, well, I think that probably depends on which system we're in a little bit. So I think if we're in the private system, it's a lot higher, perhaps nearer 80%, but in the NHS, maybe nearer 20%. 2 to 4, again, private sector 20% and NHS more 80%, and I've got 3 to 4 for about 90%. So does that help? I think we don't know the answer, but we are going to publish it soon, so in the summer.
Yeah, and I think just with the thought of what percentage can actually achieve stability, I mean, for me, that is really whether the patient truly wants to achieve stability. Long gone are the days where we buy into the concept of non-treatable disease or refractory disease. So it's about how far the patient's prepared to commit, how far they're prepared to go in terms of the steps. You know, we regularly, certainly in specialist practice, I appreciate that's a bit of an ivory tower, but we regularly get patients to well within the defined limits of true stability. But I appreciate we have a self-selecting group of very, very motivated patients, but it is achievable by the majority if they want it, don't you think?
I do. And you know what? It's such an important question, and we don't know the answer actually, and we don't have the research. We are just using our knowledge at the moment. So when this really exciting white paper, it's a position paper actually, is published, I think this will tell us a lot more about this sort of thing. We've had a group of experts, the top periodontists in the world, talking about it, and we will share that information with you. So it's yeah, something to look forward to in the summer.
Great. So a question, it's more on terminology really. Are we to now note PMPR in place of subgingival or supragingival calculus removal? Do we still note the presence of sub and supragingival calculus deposits?
That's a good question. I think you know, you need to feel comfortable with what you're doing, but we would like you to move on to PMPR. We've got the supragingival PMPR and the subgingival PMPR, as we've said. And I think when you feel comfortable with it, I would like you to move on to these new terms, because I think it embraces everything we want to do and is much clearer and gives more detail for the notes about what's actually been done. So yes, I think we should be doing it. And the glossaries on the BSP website, because it is difficult. We've got, you know, we've got scaling of the roots, subgingival scaling, subgingival debridement, subgingival instrumentation. You know, we do use a lot of different words, and we do actually in the paper actually use some of these words. But I think we agreed in the BSP that it was time we refined what we were saying, and we thought this was a good opportunity in producing these guidelines to tell the world that we think it would be better to be using PMPR as a term. So yes.
Okay, I mean, sticking with that question, this actually came up, I think, in step 2 in Ian's webinar, Ian Chappell's webinar. You might want to answer it yourself. I know what Ian said, but a question from Sarah saying, thank you for a great series, really enjoyed it. But why is it being called professional mechanical plaque removal and not professional mechanical biofilm removal? Didn't we move away from plaque? move to biofilm, many years ago?
It's a good comment, actually, and yes, that is where we should be going. I can't remember. Was it? My view would be yes, she's absolutely right, and that's what we should be using, and certainly when we write about it, that's what we should be using. However, I think probably certain groups, if you look at Leonardo's work, have been using this term for quite a while, and when we were in the workshops, it was the automatic term we used. Probably that's the reason. And probably in the future it will change into the word biofilm. I think she's right. Yeah.
So watch this space, PMBR. Yeah. It won't be too long.
Like the bacteria, we like to keep you on your toes, don't we?
It's fine. Okay, so a question. This is more. We're going back almost to step one a little bit, and the step from step one to step two. But it'd be nice to hear your views on this, Nicola. Are we being negligent if we don't treat patients non-surgically if they have not engaged with oral hygiene, i.e. they've not reduced their plaque score by 50% or hit the 30% plaque score levels?
Well, I don't think so, no. I think, we've really got to focus here, and we should follow our processes, and the oral hygiene needs to be better, because otherwise the long-term results of the surgery will fail.
Oh, Nicola's dipped out there. I don't know where the sound's gone.
Oh, sorry, I think, I wasn't sure what happened then. The answer is we must get the oral hygiene right. It's really clear we need an engaging patient, and I think Shazad Salim, makes this really clear in Healthy Gums Do Matter, and we do need to follow this.
Yeah, I'm glad you mentioned healthy gums, because the one thing with healthy gums that people, I don't think everyone's aware of, is that it's medico-legally robust. We've got some of the highest sort of medico-legal solicitors and barristers who've looked at it and said that actually if you follow that pathway, that it's medico-legally defensible. And Shazad's pathway, the Healthy Gums Do Matter, it's not Shazad's, Healthy Gums Do Matter has that concept of the engaged and non-engaged patient. So I think it is defendable. Patients really need to take responsibility for their disease.
Yeah, I totally agree. And what we're teaching now in dental schools, or certainly here in Bristol, if the patients don't engage, then we do stay at step one, and it's okay to do that, because there is no point investing more time on treatment when that patient hasn't engaged. And one other thing I would like to say at this point, actually, which is worth mentioning, if you look at different guidelines and you look at individual papers, there is some variation in where we define an engaging and a non-engaging patient. And of course, it's a group of academics that have chosen these numbers, and it's what we feel is most appropriate. But there is a little bit of variation, a little bit of differences in the numbers, as you'll see, but don't be put off by that. Follow which guideline you like, and they're roughly in the same ballpark, aren't they, Ian?
Yeah, absolutely. And I think also we all make individual clinical judgments on every patient that we treat, don't we? And we know when the patients are making an effort, but they're struggling, and those who are making no effort whatsoever. And it will ultimately come down to a clinical judgment call and knowing your patients, as well as the academic sort of hierarchy of what we've been talking about for the last 4 sessions.
Yeah, absolutely. I mean, of course, the classic's the 4mm, isn't it? Bleeding or non-bleeding, and it's not always that at all. And you can have a 5mm pocket that's pretty stable and not bleeding, isn't it? So yeah, I really think we need to use our clinical judgment here, and we're all good at that.
Yeah. This question comes from Carol. It's a question. It sort of fits in a little bit with what we've just talked about, and a little bit with Healthy Gums Do Matter, but where does palliative care fit into supportive care? She's thinking of patients who struggle to maintain perfect oral hygiene, or patients who maybe don't want to go into step 3, maybe into specialist care. Where does palliative care fit into those patients in practice?
Yeah, it's a good question, Carol. I think that's when you use your adjunctive toothpastes and mouth rinses, and you might have to accept that an engaging patient is slightly different, and I think you use your professional judgment here. But you can use adjunctive aids, and I think that's very acceptable to do that.
Yeah, I think also, and again, not pushing healthy gums do matter all the time, but the one thing that's very good about that is that when patients go from being well, when they go into what is defined as palliative care, they are very much informed of what that means, that they're not stable, they are missing a step, there are things that maybe they could do more, and they understand that although they're in supportive care, they may not be stable. It's about minimizing the rate of progression of possibly an inevitable.
Yes, and actually there's something else I'd like to mention. I totally agree with you. When I did the systematic review with Leonardo Trombelli, but you've seen comes up a lot in the supportive perio care guidance or the recommendations, what is really interesting when you actually sit down and read all those papers, which we don't usually do, when you do that, the studies are very variable. And you know what? The majority of patients in those studies are not as you would like to think those stable patients. There are often pockets there, and it's documented in the papers. And if you take a broader approach, you could say supportive periotherapy is the majority of pockets are stable, but there are definitely some that aren't, and you are managing those in a palliative way. So the more you read, actually, the more you understand the problems with supportive perio care. And it was quite an eye-opener for me when I read all those papers.
Yeah, I've got to be honest. I remember when I started getting into perio, I always thought it was, the most measured specialty in terms of data capture, and we just knew the answer to everything. And the more I study it, the less I think we know. It's sort of 50 shades of grey.
Supportive perio, if you put a patient in, this is in the papers, the academic papers, in supportive perio care, all pockets are not for and below and non-bleeding. Let's put it that way. And it's quite evident when you read it. So it's what the clinician thinks is right for the patient and supportive perio care, isn't it? And that's our judgment again. And you can have a few.
In the real world.
Yeah, do you know it is?
Isn't it?
Exactly. So yeah, I was quite surprised when I read them all and realised it was a lot greyer than I even thought it was. You're absolutely right.
Yeah, brilliant. Thank you. This is a good question. It's not really an evidence-based question, but it does specifically relate to supportive care. It's relating to 6-point pocket charting. Should that be done at every appointment in SPT with regards to PMPR, or what's the recall interval for 6-point pocket charts in SPT?
It's a really good question, and I'm going to be a little bit vague in the answer. First of all, let's take it back a stage. How often should we see a patient? And although the research comes up at 3 to 4 months, and in the guidelines it's between 3 and 12, when you look at the algorithms like Christoph's produced, which is absolutely excellent, he's put all the figures in and comes up with bleeding scores and plaque scores and pocket scores, and then can estimate when that patient needs to be seen, whether it might be 3 months, 6 months, 9 months, or annually. That would then determine perhaps when you do that 6-point pocket chart. And I think there isn't a definite answer on that. A lot of people do it annually. I tend to do it every 3 months because the work I do and the patients that I have, it doesn't take me very long. I whiz around to do it very quickly, but I wouldn't recommend that for the majority of people. I would probably have it 6 months or annually. And the other thing that's really interesting that I think will come out soon, we're doing a lot of research in this area, is that you don't probably have to, actually it's in Shazaz's work too, you don't have to look at every tooth. So let's say we take the Ramford teeth, just a couple of teeth. We think that if you just look at those, that will give you a very good estimation of what's going on. So I've been a bit grey in the answer. I don't think there is a fixed answer on it. Use your judgment. I would definitely do it annually. You could do it 6 monthly, and then I leave it up to you after that. But there is a lot of variation.
Yeah, no, I tend to agree. I know certainly in our practice, we have our supportive care patients on an annual rolling program for that. And then if we spot disease in between that, we'll rechart if we need to. But as a rule, it's an annual, at least annually. So
I totally agree. Actually, something else that I'd like to add on, and I think people are understanding this message now, in that once a perio patient, always a perio patient. And I think we've all probably said it in our webinars in one way or another. And this is really important, because once you move the patient into a perio patient, you can't go back. So you do not do a BPE again. And we see that constantly in the notes. So once you've moved them to the 6-point pocket chart, if for some reason you can't do the full chart, or maybe you haven't got some assistance, for example, you can chart then those teeth, as I think you just said, Ian, that are failing, and then write that all the others are stable, but never go back and do the BPE, which unfortunately we do see a lot.
Yeah, very much. Quite a number of questions coming on similar topics, but hopefully we can help answer them. So a barrier that lots of people seem to be facing is, I assume there's a lot of hygienists and therapists who are asking these questions. The barrier they face, that the dentists are wanting the hygiene and therapy staff to go straight to PMPR, when hygienists and therapists are wanting to do the sort of step 1 PMPR first before moving on to step 2. Dentists seem to want their teams to jump straight to step 2. What can they do?
This is a tricky one, and it's been around, you know, there's always a comment we get, actually, isn't it, when we do a lecture. I think you have to use the guidelines. So it is quite clear on these guidelines. And if you want to use the flowchart, the infographic that we've sent out, again, it's really clear that it's critical that you go through these different steps. There is good evidence base. You know, we've done these 4 webinars, we've shown you the evidence, and you just you talk with your principal about the guidance and how medical legally, you know, this is the one to follow. And I think you need to educate the other people in the practice.
Yeah, I think there's going to be so much there from the BSP to support your arguments, that hopefully it's going to be overwhelming that they won't have any comeback on it. And the same will go for patients, because we've always had that question asked, that what about patients who expect step 2 when they haven't achieved step 1 compliance? And we can now show patients the lay version of the evidence that says we don't go to the next step until they've got their bit right. So hopefully the BSP documentation will be really supportive of all of you in practice.
Yeah, absolutely. You're absolutely right, Ian. So my next task, I've got a few more to finish this topic, is to write the lay paper and the lay infographic, which is actually incredibly hard. We're doing it, and it's harder than the other one, and the other one wasn't easy. So we are going to do it. We've got the patient forum group, which is incredibly useful, because they are they help us to make sure that we convey our message correctly. So I think, you know, that's critical. So when we've done this next stage, which hopefully will be in the next month or 2 and published in the BDJ, we will have a paper that's easy to understand for patients and for the public, with a flowchart. And the other thing that we're doing following that is I'm writing a paper with Raimondo Ascioni, going out to doctors as well, because it's probably an app or something that is more friendly towards that area of healthcare professional, but also informing them, because, you know, that we've got to target different areas here, and they've got to be simple, clear guidelines. So very soon, as you say, Ian, there's going to be a huge amount of evidence in the public domain that's easy to understand for patients and the public, that then they can use. So it's all there. It's just us communicating it, and I think you need to communicate that to your other colleagues in the practice, and probably simply with like the flowchart, or look at the BSP website, something like that.
Yeah, I can't stress enough to people who are listening how valuable the patient forum's been. I think we're the first specialist society in the UK to have patients as part of our society. I can see actually there's a few of the patient forum actually listening in tonight. That's how engaged they are with the society and helping us achieve what we're trying to achieve. They're a fantastic group.
And also the first in Europe perio, and you know, you are the first, and we put it down to Ian Needleman, of course, and helped by Penny, because we have the Scottish group now. But you know, this really is visionary thinking, and we have a patient forum a representative on council. I mean, again, this is, you know, it's really visionary, and it's so important that we are thinking like this, because our communication about this perio disease, which is, as I said, in the majority preventable, you know, has to be better. And we're doing everything we can to help this. So yeah, I totally agree. Thank you for coming, listening this evening. I hope you're enjoying it. And yes, we've got some work to do. Something will be coming to you shortly.
Yeah. We've got a few more to go, if that's okay. It's only 8:20, so we'll keep going a little bit longer, because obviously it's the last one, so people are desperate to get their questions in. If during a single appointment, and then in brackets it says I only have short appointments, maybe 20 minutes, I can't remove all of the calculus and plaque, do I still write down PMPR in my notes?
I think you do need to start using that term PMPR, but you might clarify into exactly which procedures in the PMPR you've done. I think I'd probably say that. Interestingly, we're all lecturing those, Ian and Chappell and Moritz, and one of Moritz's lectures, he says that, you know, he'd like an hour for this. And I was thinking that would be brilliant, but actually it's pretty difficult to get that amount of time, isn't it, to look at a patient and do the behavior modification and the PMPR and everything else you've got to do. So I do appreciate that a lot of us have a lot less time.
Yeah. A question relating to actually management of gingivitis, would that also be would we also write and record PMPR for gingivitis patients?
In step 1, then yes.
Okay, yeah, great, nice easy answer. Okay, so again, slightly off step 4, I'm afraid, but it's sort of about moving into step 4. If we've got smoking patients who've had RSD, or as we now call it, PMPR, and they still have residual pockets, do we consider another round of PMPR, or do they go straight into supportive care given that they are smokers?
Yeah, really good question. And I think, I'll talk for myself here, as I get older, you change in your views, how you treat. So when I was younger,
there we go,
I was doing a study with Richard Palmer.
Sorry, Nicola, you're breaking up a little bit.
Oh, I'm sorry. Can you hear me now, Ian? Sorry, the internet looks good, but I hope can you hear me? I don't know that you can.
That's better. I could hear that.
Yeah, sorry.
Try again.
Yeah, sorry. When I was younger, I did a study with.
Again. That's me saying that we were nearly finishing the web.
Sorry, I don't know why this is happening. The internet looks good, but I'll try and tell my story. But I've got a feeling you can't hear.
Go for it now.
Okay, so I'll do it quickly. I did a study with Richard Palmer, and we were looking at, it was to do with implants. And I said, well, we can't have any smokers on the study. He said, of course you can. I said, no, we've got to be really strict here. And he said, well, Nicola, you've got to be reasonable and pragmatic. And now I'm older now, I think a little bit more like that too. So my view is that patient has to demonstrate that they have reduced smoking, that they've made an effort, that, you know, that they're doing the best they can, and then we can be a little bit more reasonable. So I'm going to leave that one open, but the older I get, the more reasonable I am.
Yeah, I mean, I'm very comfortable with more than one round of non-surgical management. I think we all think twice about surgical management in smoking patients, but yeah, certainly non-surgical.
Yes, we're in the real world here, and as long as that patient's comfortable, you know, we've documented everything down well, then and the plaque control's good and all those other things are right, then yes, there's a little bit of grey.
Okay, this is a bit of an NHS specific question, which you may or may not be able to answer. Ian, I think, touched on this a little bit. He gave a little bit of a secret away, but didn't go too far with it. But the question is with regards to staying at step 1. So patients who maybe need multiple visits of oral hygiene and behavior modification, How long can we really justify keeping going at that stage? The NHS dentists don't like to keep that stage open for too long.
Yes, I work in the NHS, but in a hospital environment, which of course is very different to NHS practice. What I will say is that I think this is going to change soon. Ian has been instrumental in working with the OCDO office on the transition back to care. I think it depends. How long a cot can be open really depends on the local health authority, from what I understand. I don't know too much about it, Ian. I think you probably have to follow your local rules, or the local health authority.
Yeah, I think at this point it is difficult, and I think Ian Chappell did give a little bit of a sort of a hint that they're working with paymasters based on this evidence-based approach to look at the way we remunerate perio. So hopefully we'll see things change. But yeah, he hasn't given a lot away. Even we don't know a lot about what's going on. So.
He has done a brilliant job. I've seen the flow chart, I've seen the proposal, and I have to say, I think we are incredibly fortunate, and the people have worked really hard here to establish these guidelines to be able to have an influence in the health policy. You know, I think we're the only society that have our feet under the table like that, and I have to thank Ian Chappell for that. And I think if you keep your ears and eyes open, you will see some changes in this next year that will really support looking after the oral health and the perio health of our patients, and remunerate it correctly as well, because we all know that you know, it takes some time to go through all these steps. So I think it's coming.
Watch this space.
Yes, I think that's the way to leave it. Yes.
Yeah. Always leave people wanting more. That's the way to do it.
We've got lots coming. Yeah.
Right, we're probably going to come to a close in a second. There's a question here. Patients who complete stage 2 or step 2, but are in areas where there is no NHS step 3. So basically there is no NHS surgical management. What can be done if patients have got limited funds and they can't be referred into the private sector?
Yeah,
Step 4?
It's a good question, isn't it? Do you know, it's not right, is it, that I don't think it is, that if you need to do surgery, it's under you know, that band 2. So I think if you feel the patient needs surgery, then they need to be referred, and that's either to a teaching hospital, which I do appreciate is not near everybody, or into the private sector, or else you have to manage, as we've shown on the flow chart, and move them to step 4. So I think it is a tricky one. I think you have to use your judgment there.
Okay, last one.
It will change later this year. So yeah, again, watch the space.
Do we still use the term PMPR if we've only used hand instruments, i.e. no mechanical instruments have been used?
That's a very good question. The answer is, if you've achieved everything, then yes. You know, you've achieved what you need to achieve. I think, do you agree with me, Ian?
I totally agree. I mean, the term is professional mechanical plaque removal. It doesn't tell you how to do it. The step 2 actually says it can be done with hand or powered or both. It's very clear in step 2. So I think,
and of course, yeah, we use power because it's a lot easier for us. But actually, I like using both, and the evidence, if it's done well, is equivocal. Yeah.
I think the point that Victoria is probably making is the M in the PMPR, so professional mechanical. Mechanical is that we are physically removing it with instruments. I think it's not phonics only. Step 2 is very, very clear on that, very clear.
Yes, and all the evidence has always said that, actually. We've always said, if you look at our GPG, our good practitioner guide, that hand instruments can deliver the same as the ultrasonic instruments. the evidence is equivocal. Yeah, it's the same.
Brilliant. Well, I'm really conscious of time, and although there's no football tonight, I'm still conscious that we've all had very long days, and we could probably sit here all night. I'm going to thank Nicola for a fantastic presentation and for giving her time. I know she's actually feeling a little bit under the weather after a second jab vaccine, so she's done very well to get through this tonight, and I thank you for that. Thank you again to Oral-B for supporting us this evening. And thank you all for listening, and we will hopefully see you at one of the next webinars. Keep an eye on the BSP website for what's coming up in the near future. Thank you, everybody.
Thank you, Ian.
Thanks, Nicola. Good night.
Good night.